Chairman, ladies and gentlemen. My topic will be on statins, and I will focus on Pitavastatin as the last statin we know. It's well known that statins are the best preventive drugs available. They are effective, they are safe, and we can get net clinical benefit when we use them, and of course they are cost effective. As you can see in the slide, the first statin was introduced in 1976, and after that time there was a significant decrease in the rate of death due to cardiovascular diseases. So the statins are extremely important in decreasing the cardiovascular events. And also there's compelling reduction in the events with statins, and there's growing evidence. And as far as we know, they're effective in the primary prevention in high-risk patients and also in the secondary prevention. And in most of the populations they are studied, they are very effective in reducing the events, also in regression to atherosclerosis. We can get net clinical benefit. There are nearly millions of people enrolled in these studies, and except the hemodialysis patients and heart failure patients, in all populations, statins give us good results in terms of reducing cardiovascular events. Therefore, all guidelines suggest that the statins are the #1 drugs in the prevention of cardiovascular disease. And first, I want to go on with American guidelines. As it was mentioned in the previous speaker's slides, this guidelines introduce 4 different patient groups that can get benefit from the use of statins. These are the ones with clinical cardiovascular events, namely the secondary prevention patients. The second group that can get benefit from statins are the ones with high LDL cholesterol exceeding 190 milligrams per deciliter, namely the FH patients, and these are in the primary prevention. And the third group are the diabetic patients, and the fourth group is the ones in primary prevention, not diabetic, but having the risk higher than 7.6%. So these 4 groups are the ones that can get the highest benefit from the statins, and I wrote in red that these groups can get these benefits if we use the related intensity of statin therapy. These are low, moderate, and high. Low intensity statin treatment defines that where we can get LDL reduction by 30% with the daily dose of the statin. These are the low doses of these statins, as you've seen. Also, Pitavastatin 1 milligrams per daily in this area. The moderate intensity statins can be described as daily dose that lowers LDL cholesterol by approximately 30 to 50% on average. Here we see the low doses of atorvastatin and rosuvastatin, and also the pitavastatins 2 and 4 milligrams per daily are in this group. And as you know, the high intensity statins is described as the daily dose lowering LDL cholesterol higher than 50% on average, and these are the higher doses of both atorvastatin and rosuvastatin. In the European guidelines also suggest that the statins are the #1 drugs to be used in the hyperlipidemia, and they should be used on the highest dose recommended or highest dose that are tolerated to reach the goal. And to reach the goal, European guidelines give us a graphic that shows all the low and higher doses of the statins, and also this diagram gives us the equivalent doses of the statins. And as you can see here, pitavastatin is in the range of moderate to high intensity statin group. As you see, statins vary in chemical structure, and as I have to focus on pitavastatin, it has an additional cyclopropyl group in its chemical structure. And this chemical structures gives this molecule an additional properties, such as there can be some differences in its metabolism. It is bioavailability is better than the other ones. It has a longer duration of action, and also it is not metabolized by the cytochrome 3A4. As you know, this is the ones that many other drugs are metabolized. So drug-to-drug interactions are expected to be low with the use of pitavastatin. It is moderately lipophilic. It has good oil absorption. It has a high bioavailability. And as I said, it has a longer half-life. It is about 9 to 12 hours. And it is not affected by the food for absorption. And it is not, as I said, metabolized by cytochrome 3A4. It has a good effect on lipid profile. I showed this diagram in the previous slide. That is moderate intensity to high intensity group of statin, and its effect on LDL is comparable to the other statins. But interestingly, as you can see in this graphic, the red lines show that pitavastatin has the highest effect on HDL increasing when compared to the other statins. And in terms of pletropy, like the other statins, it decreases the CRP levels and inflammation. There are many studies for that. It has a good impact on adiponectin levels. It increases the ApoA1 levels when compared to the other statins. And also it affects the oxidation biomarkers in a good manner when compared to the other statins, and also antioxidant properties has been shown for this drug. And most importantly, this drug has been shown to regress the atheroma. As you know, this is very important because regressing atheroma plaque means that this agent will also decrease the cardiovascular events, and this was shown in many previous agents. And for example, I want to share you a study that was published in JACC, and it was a post-acute coronary syndrome study, and it has enrolled more than 200 patients who has undergone primary primary percutaneous intervention, and patients were randomized to pitavastatin or atorvastatin. You see the equivalent doses, and the follow-up period was about 1 year, and at the end of the year, the LDL reductions were similar between the groups, and also the atheroma volumes were reduced similarly. So this agent can regress the atheroma like atorvastatin, which was shown to be significantly atheroma regressive agent. This is another study I want to share with you. This is also enrolled patients with acute coronary syndrome, and all patients has undergone emergent PCI. The number of patients 160, and all patients were evaluated by IVUS after 2 to 3 weeks of the treatment, and the patients were randomized to either pitavastatin 2 milligrams per daily or atorvastatin 10 milligrams per daily. And LDL reduction was very similar between the groups. However, the plaque volume index and fibropathic volume index, which define the atheroma properties, was reduced in the pitavastatin group significantly, but unfortunately it was increased in the atorvastatin group. So this is another important study that's showing pitavastatin can lead to regression of the atheroma in the high-risk patients in the early period of acute coronary syndromes. And what about the coronary cardiovascular events? Unfortunately, this agent has no cardiovascular events determining studies because it's now unethical to perform a study comparing the effects of this agent versus placebo. But we have the real-life data coming from Japan. Patients between 2001 and 2008 were enrolled retrospectively and evaluated. The number of patients was higher than 700, and all patients were using either atorvastatin, pravastatin, or pitavastatin. And as I said, this is a real-life data from Japan. And this data showed that event-free survival was the best in patients with using pitavastatin, either with HDL levels higher than 45 milligrams per deciliter or less than that limit. So when compared with the other statins in real-world setting, pitavastatin was effective in reducing the cardiovascular events. Another real-life data from Japan, this time the number of patients is 20,000 patients. The follow-up period was 2 years, and also it included an extended 5 years follow-up. And this data also showed that that in patients with LDL cholesterol attainment with the use of pitavastatin, both the cardiovascular and cerebrovascular event rates were decreasing, and this risk reduction was higher than 50%. And also it was the same for the patients attaining the HDL goal. There was an additional nearly 60% risk reduction if HDL target was attained over the limit of 40 milligrams per deciliter with the use of pitavastatin. What about the safety? There are data showing, there are data showing that coming from that previous real-life data and also clinical trials that there is no severe increase in the risk of adverse event with the use of this drug. And also in the slide you can see that this is another real-life data coming from, again, from Japan between 2004 and 2011. When you compare with other statins, pitavastatin was extremely safe in real-life setting, and also it doesn't have an adverse event on glycemic control in people with type 2 diabetes. So, in conclusion, in the beginning of my slides, I said that statins are super in the treatment of, and they're the best preventive drugs. And pitavastatin, as the newest agent added to this group of HMG-CoA reductase inhibitors, it is safe, it is effective, and we can place it in the moderate intensity to higher intensity statins, and we can use it safely to reduce the cardiovascular events. Thanks you for your attention.